What's up? I'm Zach from Dr. Eyeball MD, and today we're going to go through a few parts of my day as an ophthalmology resident. Let's go. All right, guys, walking in, late start to the morning today. No lecture, because it's the first day of the new rotation. Starting at the main general clinic here at the Central Hospital. So I have a full clinic day, 118 patients, I think, split between about 4 of us. So we'll do that. In the morning, have a break for pathology with the ocular pathologist for a few hours, where we go over histology slides of ocular surgical specimens, looking for different diseases and things under the microscope. So we'll do that around 10, then we'll head back to clinic and spend the rest of the day in the clinic. Probably till about 5 or 6 p.m. I'll keep you guys updated. All right, guys, so it's about noon now. I've only seen about 7 patients. There was no pathology this morning, but so far we've already done 3 injections of Avastin, which is an anti-cancer drug that's been adapted for use in the eye to treat bleeding and diabetic retinopathy, proliferative diabetic retinopathy. The way that works is basically we take a 1 cc or 1 milliliter syringe and we place a 30 gauge needle on the end of it. We numb the eye pretty well with the medicine, a drop called proparacaine, and I also use lidocaine. I feel like patients really like it when they numb their eye with the lidocaine, so that's what I normally do. And I'll just take this, it's 4% topical lidocaine. I soak a Q-tip in it, and then I'll actually place the Q-tip. I'll pull down the lower eyelid and place it down in the lower fornix down there and have them close their eye and let it just sit there and numb right over the pars plana where I'm going to put the injection. And I let them sit there for about 2 minutes. I work on the computer while they get numb, so it's efficient, and I feel like it's better for their comfort because it hurts a lot less. But then we do the injection. We do 0.05 cc's of the Avastin right here through the white part of the eye, about 3.5 to 4 millimeters from what would be the colored part of the eye, or the limbus, which is the end of the cornea, basically. So if you're looking at the eye, you see the colored part, the iris, you go about 3 millimeters away from that, and that's where we put the injection of the medicine into the eye, into the vitreous cavity, to treat things like diabetic retinopathy. But we've already done 3 of those. In this past year of residency, I've already done probably close to 400 injections, which is a lot. So something we get pretty good at is doing those injections. Anyways, we'll keep going for the afternoon. I've got quite a few patients left to see in the afternoon if they all show up. So we'll go from there. So the next patient I'm about to see is a 66-year-old guy who we'd previously done cataract surgery on 5 years ago, lost a follow-up, and now he's coming back from his optometrist for a vitreous hemorrhage in the right eye, which is basically just bleeding inside the eyeball into the vitreous cavity from diabetic retinopathy, most likely. Previously had non-proliferative diabetic retinopathy, now most likely proliferative diabetic retinopathy with this new bleeding. So for him, what we'll need to do is do an injection of Avastin, like we talked about earlier, into the eye to reduce more bleeding and give his eye time to try to clear the vitreous hemorrhage. And then depending on how quickly it clears or doesn't clear, he may need surgery to remove the blood, but we'll see. So I'm gonna go get him and we'll need to do the injection. So here's the needle that we use. It's a 1 cc syringe with a 1/2 inch needle on the end. There's my hand for comparison. So that needle will go inside the eye, through the white part of the eye, about 3/4 of the length of that needle. All right, on my way home now. Just finished clinic about 20 minutes ago. It was about 4:30 when we got out, so pretty good day. We actually finished a little earlier, but I was finishing up with getting my patient situated for grand rounds. What grand rounds is essentially the way we do it in our program in ophthalmology is we find a patient who has a disease process that's not entirely clear what's going on or what the diagnosis is, or sometimes we know the diagnosis but we don't have a solid treatment plan or exactly how to go about it, or maybe there's more than one way to approach the treatment plan. So what we do is the first year ophthalmology residents will find the patients three different patients for 3 different residents, and we'll present those patients. So all the faculty will come, the other residents, some of the fellows, and then everybody can look at the patients, actually examine the patients there, have a chance to see them firsthand, and then the patient will leave, and then we'll go into a different room, a conference room, and actually do a PowerPoint presentation where we give the patient's full history, the physical, all the exam findings, and the imaging and so forth. And then from there, we discuss, mostly it's attendings discussing either what they think the diagnosis is, what they think the best treatment plan is, if that's what's in question. And the way our grand rounds are structured is it's typically structured so that the question needs to be like, what is the best management going forward? So it needs to be a question of management. So that's what I was doing today. Was I found a patient that I think will be suitable for grand rounds, and today's Monday, so I need somebody to present by Friday, and I have to have the presentation together by Wednesday night to send in to the education office. But so I found a good one. It looks like she may have bilateral third nerve palsies, at least partial third nerve palsies, which is not common, and it's not entirely clear the source or the etiology of it. So it'll be kind of a question of diagnosis, and then also further workup that we might need, like other imaging, like a CTA or MRA possibly. So that's the patient I got, and I was getting all the imaging she would need, doing all the exam stuff, just so I could get it all teed up for the presentation on Friday, which we'll have Friday morning. And hopefully they come. Sometimes they don't show up, and then the residents get in trouble for it, although there's not really much we can do about it. But sometimes people don't come. So hopefully she comes and everybody can, be able to see her, and then I can present her. And then if we find anything new, I'll relay that to her. So that's kind of what grand rounds is and how it's structured. All right, so that was just a few parts of the day. Moving forward, I'll try to show you guys a lot more videos and a lot more in depth of what my day looks like. This is just the first video in this for this channel, so it'll get better and better. And I'll try to teach you guys some things. If you have questions about, different eye procedures or diagnoses, those kind of things, just ask me down in the comments below, and I'd love to talk about it. Hope you guys like it. I'm Zach with Dr. Eyeball MD. I'll see you guys next time.